saying with this talk, most of the time we are not really looking over the inter-speciality relationships. Inter-speciality relationships are largely being ignored and we have been confined to our specialties. The same thing is happening is when we talk about the non-alcoholic fatty liver disease. तो जब भी हम non-alcoholic fatty liver disease की बात करते हैं तो हमें क्या लगता है कि यार समथिंग कुछ ऐसा है जो कि अल्कोहलिक फैटी लिवर डिजीज में होता है, पर अगर ऐसे आदमी को भी हो गया जो कि अल्कोहल नहीं लेता तो शायद हम इसे नॉन अल्कोहलिक फैटी लिवर डिजीज कहते हैं. बट वी नेवर हैड दिस थिंग इन आवर माइंड कि दिस नॉन अल्कोहलिक फैटी लिवर डिजीज माइट बी हैविंग सम रिलेशन विद सम अदर डिजीजेस आल्सो. There are n number of the reasons of the non-alcoholic fatty liver disease, multiple causes of the NAFLD, and out of those very important causes the metabolic reason, metabolic syndrome, obesity, diabetes, and many things which are arising out of the insulin resistance. So that's why to strengthen this inter-speciality relationship between the metabolic science or endocrinology and hepatology, this term has been now stopped to be used and is being changed to the MASLD. MASLD is metabolic associated steatotic liver disease. Steatotic liver disease means the same fatty liver disease if it is occurring in our body because of the metabolic irregularities. Those metabolic irregularities may be diabetes, those metabolic irregularities may be obesity, those metabolic irregularities may be hypertension. So, by all those metabolic reasons, this healthy liver gets changed into the unhealthy one by just the deposition of the fat, what we call as steatotic liver disease. So, renaming of the NAFLD as MASLD. Now, what is very much important for renaming and defining this MASLD? When we were talking about the NAFLD, it was enough for us that liver is having fatty deposition, and this fatty deposition is more than 5% of its total space. But once we are associating it with the metabolic reason, then again it is very much important that some metabolic disease must be associated with that. So, steatotic liver disease means fatty deposition which should be more than 5% of the fat in liver is associated with cardiometabolic risk factors. Those cardiometabolic risk factors may be related to the insulin resistance, those may be obesity, those may be hypertension, those may be dyslipidemia, all those cardiometabolic risk factors. If any of those cardiometabolic risk factors is present, we shall call it MASLD. So how this new nomenclature has been established? A total of 236 panels from 56 countries sat together. 74% of them felt that current nomenclature is not really sufficiently taking the name of its worth. The term non-alcoholic and fatty were felt to be stigmatizing by 61% and 66% of the respondents. The steatotic liver disease, or what we call it fatty liver disease, was chosen as an overarching term to encompass the various etiologies of the steatosis. So it does not really serve the purpose for the specific metabolic associated liver disease. In overall, 75% of the respondents of that external expert committee chose metabolic dysfunction associated steatotic liver disease, which was in short called as MASLD, as the replacement term for the NAFLD. I think this would be very good thing for those who are going for the examination. They may be asked these kinds of the things which are quite correct again. This renaming as MASLD nomenclature were released in June 2023 by ESL conference, in which all these organizations whose logos you can see on my desktop, they are accepted and they have been in agreement of changing this nomenclature. So steatotic liver disease is a broad spectrum of the disease, And that spectrum actually encompasses from the metabolic dysfunction which is associated with the liver disease, ranging from this to encompassing liver disease which is not associated with the metabolic reason, alcoholic liver disease, and then finally there are some specific reasons for the liver disease, like some drug-induced liver disease, like monogenic disease, which may arise because of the hyperbilirubinemia, that may arise because of the inborn errors of the metabolism, Wilson's disease, and finally the cryptogenic, means no cause we could establish for that kind of the steatotic liver disease. So which type of a patient will be considered as MASLD? If he is having 5% and more than that fat in his liver with one of the 5 cardiometabolic risk factors, maybe elevated triglyceride level, maybe low HDL, having the type 2 diabetes or pre-diabetes, obesity and high blood pressure. Out of these, anything is happening, then a person would be considered as a patient of MASLD. Now question arises, what should be the management? How should we move for the management of the MASLD, and why it is very much important to be managed? As it has been emphasized multiple times, it has been emphasized by Professor Sachan also, that now a disease is not only affecting the organ in which it is being started or it is being largely affected to that, but actually it is impacting rest of the body organs also. The same thing happens with the MASLD also. Once we see that steatotic liver disease or fatty deposition in the liver is taking place, it is not only impacting and making the liver unhealthy, but also having an impact on the cardiovascular system. It is having an impact on the chronic kidney disease. It takes us towards the obstructive sleep apnea, what our sleep experts would be telling you more about that. Endocrine conditions, maybe multiple endocrine conditions may be associated with the obesity, hyperinsulinemia, insulin resistance would be coming up in the way. It may also become the carcinogenic and also lead to the multiple infections, and few of the outcomes may be quite specific which are reported by the patient. So NAFLD is one of the very important reasons for type 2 diabetes. Now it is very much difficult to decide whether the type 2 diabetes is giving rise to the NAFLD or NAFLD is giving rise to the type 2 diabetes. But the correlation is very strong. You can see by that meta-analysis of the 33 studies in which 5,01,022 patients, those who were having 30.8%, approximately 31% of them were the NAFLD. And 27,953 cases of the incident diabetes over a median of the 5 years. What was the result of this meta-analysis? All NAFLD patients out of the 26 studies could be seen that 2.19 was the relative risk for the incident of diabetes mellitus. Means, कहने का मतलब ये हुआ, overall, those who were having the NAFLD, 2.19 of them were more getting the type 2 diabetes as compared to those who were not having the NAFLD. Similarly, the patient, those who were having the severe NAFLD, they were having little higher risk of getting the type 2 diabetes, which was 2.69. And liver fibrosis were having further higher risk, 3.42 times more than those who were not having the NAFLD. The people, those who were having the NAFLD, they were more than 2 to 3 times more prone to develop type 2 diabetes as compared to their non-NAFLD counterpart. So NAFLD is associated with a overall 2.2-fold increased risk of the incident diabetes, which directly proportional to the severity of NAFLD. More severe NAFLD, more chances of getting a type 2 diabetes. Less severe NAFLD, less chances of getting type 2 diabetes. And very good thing is that this is preventable. This is reversible. If you anyway can do anything to stop this progression of the NAFLD, or any way you can reverse this NAFLD, then you can stop the occurrence of type 2 diabetes which is forthcoming. Now question arises to little bit understand about the pathophysiology of this NAFLD. ये NAFLD होता क्यों है, कहाँ से आता है NAFLD? NAFLD और डायबिटीज दोनों का जन्म इंसुलिन रेजिस्टेंस होता है. Both are taking their roots from the insulin resistance. And what happens once the insulin resistance sets in? The two very important things happen. Hyperglycemia, हम सबको पता है, insulin resistance हुआ, type 2 diabetes हो गई, hyperglycemia हो गया. The same part of the patient, those who are developing hyperglycemia, before development of the hyperglycemia, क्या होता है? They try to combat that insulin resistance. They try to mitigate that insulin resistance by hyperinsulinemia. Insulin resistance आया, इंसुलिन ने काम करना कम कर दिया. अब उसके रिस्पॉन्स में पैनक्रियाज ने ज़्यादा इंसुलिन बनाना शुरू किया, तो आप हाइपर इंसुलिनीमिया में आप अपने पेशेंट को देखते हैं. वो हाइपर इंसुलिनीमिया की जब फेलियर हो गया तो पेशेंट हाइपरग्लाइसीमिया में गिर गया. So these are the two situations are there, and both are very much detrimental for the healthy liver because they lead to the adipocyte dysfunction. जो फैट सेल्स होते हैं उसका डिस्फंक्शन या उसका डिटेरियोरेशन कॉज करके दे इंक्रीजेस द लेवल ऑफ द ब्रोकन फ्री फैटी एसिड. So free fatty acids are gets increased in the blood with reduction in the level of adiponectin. Adiponectin is a hormone which is working against the adiposity, and once its level comes down, then adiposity is flares up and it increases up. It gets increased, and that adiposity actually takes us towards the larger size of the fat cells and leading to obesity. So once it happens, then the healthy liver becomes unhealthy. First, it's simply because of the fatty liver deposition, and once the fat in the liver is increased up to the larger extent, then it starts developing the lipotoxicity. It starts developing the inflammation, programmed death of the liver cells, and ultimately ending up with the deposition of the oxy-free radical to NASH, which is also known as NASH, non-alcoholic steatotic hepatitis. And this ends up with the end-stage liver disease. That end-stage liver disease may be cirrhosis. That end-stage liver disease may be hepatocellular carcinoma. So what happens here? What is the big picture across the world? पूरे दुनिया भर में 25% people are having NAFLD. 38.6% प्रेवलेंस इंडिया में है NAFLD. और जो सबसे बुरी बात है जिसको कि हम में से शायद कोई भी अप्रिशिएट नहीं कर सकता, दैट इज 35.4% इन पीडियाट्रिक एज. तो हमारी जो आने वाली जनरेशन है विच इज सफरिंग विद NAFLD वेरी अर्ली, एंड इट्स रियली नीडेड टू बी स्टॉप्ड. 58.2% it is seen in all those patients, those who are suffering with the metabolic disorder. Diabetes के करीब 70 से 80% लोगों के अंदर NAFLD मिलता है. So this NAFLD is actually taking the shape of the epidemic, which epidemic is maybe in the forthcoming days larger than the diabetes. So commonly associated metabolic conditions with the MASLD can be enumerated as obesity, type 2 diabetes, hypertriglyceridemia, dyslipidemia, hypertension, and polycystic ovarian disease, which has recently been added to these causes. Now we can see a lot of young girls are suffering with polycystic ovarian disease. And what is the percentage of their association? You can see here the largest association is of the obesity, followed by the hypertriglyceridemia. MASLD is associated with higher cardiovascular events, and these cardiovascular events takes place through the same mechanism what we see in our other any diabetes patients or macrovascular complication mechanism of the type 2 diabetes. Vascular inflammation takes place. That vascular inflammation invites the deposition of the liver invite the deposition of the lipids. And once this lipid deposition takes place, उसके पहले क्या होता है? Lot of platelets are getting collected there, and those platelets make the way for the deposition of the lipid molecules, and then vascular remodeling takes place. Finally, it ends up with the endothelial injury and hypercoagulability, ending up with the cardiovascular disease. तो CAD की जो बुनियाद है वो डायबिटीज होने के 10 से 15 साल पहले उस समय रख दी जाती है जब पेशेंट को NAFLD या फैटी डिपोजिशन होना शुरू कर 5% फैटी डिपोजिशन इज टू लो, वेरी डिफिकल्ट टू इवन नो अबाउट दैट। थोड़ा सा भी हमने अपने बच्चों में आजकल हम लोग देखते हैं बिकॉज मोस्ट ऑफ द किड्स आर नॉट रियली गोइंग फॉर द physical activity, they are playing on their mobile, everything, they are doing all the activities sitting at one place on the computer, and this is giving rise to the deposition of the fat, and ultimately this is establishing the endothelial dysfunction in them, which endothelial dysfunction will give rise to the atherosclerosis, causing the CAD and other such kind of diseases when they will become adult. And this is one of the important reasons because of what we are seeing, the sudden cardiac death. We are seeing the MI in the ages of the 20s and 30s now very frequently. MASLD is associated with more cardiovascular events as mortality. So prevalence of the MASLD is more common than NAFLD. MASLD is associated with more cardiovascular events and mortality, and you can see this difference is not little bit different. This difference is very huge. You can compare it. NAFLD is the blue one and MASLD is the orange one. So against the 9% risk of the cardiovascular event which were there in the NAFLD, MASLD which fatty deposition associated with the metabolic condition having a 43%, even more than 4 times. And when we talk about the fatal cardiovascular event, you can see again it is around 4 times. And when we talk about the cumulative all-cause mortality, you can see it is about 2.5 times higher in the metabolic associated fatty liver disease. So in type 2 diabetes, progression of the NAFLD to cirrhosis and related mortality is higher. So once we compare these two groups, those who are having the NAFLD but not diabetes, and those who are having the NAFLD with diabetes, what is the difference? Largely you can see it here. Out of those who are not having the type 2 diabetes, 10 to 20% convert into the NASH, means inflammatory condition, and out of those who convert into the NASH, 10 to 15% gets converted into the cirrhosis, and 3% of them develop the hepatocellular carcinoma, and 13% die of them, and those who develop the hepatocellular carcinoma, 43% die of them. About 14% gets the liver transplantation, and 21% patient of those who get the liver transplant die. But once it is associated with diabetes, then you can see the picture is very dangerous. Out of those NAFLD who are associated with type 2 diabetes, 40% converts into the NASH. That is the inflammatory non-alcoholic steatotic hepatitis. And out of those NASH, 20 to 25%, which is against 10 to 15% from the previous group which was not having the diabetes, those 20 to 25% get cirrhosis, and 5% of those cirrhosis converts into the hepatocellular carcinoma, and 25% is the mortality rate, which is just double of the non-diabetic NAFLD. Non-diabetic NAFLD means cirrhosis patients who are having the 13% mortality, here the cirrhosis patients having 25% mortality. And even those who get the liver transplant, 42% dies of them if they are having type 2 diabetes with them. Again, those who are not having the type 2 diabetes, only 21% people are dying after the liver transplant. So liver transplant mortality or after the liver transplant mortality also gets double when it is associated with the type 2 diabetes. Now question arises, what should be the diagnostic approach? What has been recommended by the guideline? Algorithm for the diagnosis of the MASLD or NAFLD say any patient who comes to you with elevated liver enzymes which are not really explained well, you should ask him to get himself investigated for the NAFLD or fatty liver deposition. If the patient is associated with any condition which may be arising out of the insulin resistance, that may be obesity, diabetes, or metabolic syndrome or hypertension, then it becomes more important and you need to ask him for a fatty liver screening through the abdominal ultrasonography. If patient is found to be having evidence of the fatty liver disease through the ultrasonography, obviously it becomes a candidate for the treatment. But if it is not, then we can ask him to go for the non-invasive testing for the fibrosis, that is the Fibroscan. And if he is found to be the low risk for the Fibroscan, which is around less than 3, then probably we should ask him to come again every 2 to 3 years. But if it is found the intermediate risk or high risk, then he should be taken towards the vibration controlled transient elastography as well as blood test for the measurement of the fibrosis, how much part of the liver is getting fibrosed, how much part is still having the liver, fatty liver disease, and we should start the treatment accordingly with such patients. So in this MASLD patient, the biggest drawback is they are asymptomatic. All major guidelines with all organizations across the world, they are saying even if the patient is asymptomatic, you should start doing the screening for the factors which may be detrimental in patients of the NAFLD. If you can see any patient who is having the NAFLD, who is having the fatty liver deposition, you should screen him for the type 2 diabetes, obesity, metabolic syndrome in the form of the hypertriglyceridemia, low HDL and hypertension. And screening methods could be the abdominal ultrasonography, Fibroscan, transient elastography. All methods are strongly recommended by all the guidelines. Now the question arises, fibrosis score, FIB-4 index is to evaluate advanced fibrosis, how much useful and beneficial. It is easily available on the web portal. Least invasive method it is. Only 4 parameters you are required to calculate. What are those 4 parameters? You need to know about the SGOT, SGPT, age of the patient and platelet count. These 4 things you need to know about that. And this is the quickest way to evaluate the probability of the fibrosis. Higher positive and negative predictive value cost is least whatever the available tools are there. But there are certain limitations that it is not a confirmative assessment and need further evaluation through the liver biopsy or vibration-induced elastography. So vibration controlled transient elastography is another very important tool. And Fibroscan is dedicated system which used to evaluate advanced fibrosis through this technology. So what are the parameters what we measure through this technology, which is the vibration controlled transient elastography, Fibroscan? We need to measure the 2 important things. One is the liver stiffness and other is the controlled attenuation parameters. And liver stiffness is actually measures about the quantification of the fibrosis, while the controlled attenuation parameter gives you the quantification of the liver fat deposition or liver steatosis. If we have the higher CAP score that suggests high amount of the fat, as I have already said to you, that controlled attenuation parameter gives you about the deposition of the fat or amount of the fat. So these are the scores through which you can grade the steatosis grading and amount of the liver showing the fatty changes. Meaning if somebody is having a CAP score less than 237, then he is found to be keeping in grade 0 and having less than 10 amount of the liver, less than 10% fatty changes in the liver. When it is 238 to 260, it is the grade as 1, having 11 to 33% liver is having the fatty changes. 261 to 292 is having the 34 to 66% liver having the fatty changes. If it is more than 293, then it is stage 3, more than 67% liver is having the fatty changes. As far as the LSM score is for the measurement of the fibrosis. LSM score, if it is 7 or less than that, it is called stage 1. No fibrosis is considered. If it is between 7 to 10, stage 1, mild fibrosis. Between 10 to 30, stage 2, moderate fibrosis. Between 13 to 16, stage 3, severe fibrosis. And more than 16 or equal to 16, stage 4, which is considered as equivalent to cirrhosis. Now question to the management approach. Lifestyle modification is actually the only management available, which is the sure shot management. So once we talk about the management of the MASLD or NAFLD, lifestyle modification, which includes the diet management and weight reduction, that is the key for the management. Comorbid conditions to be handled with effectively, like obesity, type 2 diabetes, metabolic syndrome. Then it comes to the pharmacotherapy, and finally it should be bariatric surgery. So non-pharmacological approach, once the weight loss and exercise, diet and bariatric surgery. These are the three non-pharmacological approaches. People, those who are ready to lose their weight, those who are ready to do the exercise, they are the luckiest person on this earth. They can handle their problem very easily. They can stop themselves going to the dreaded end simply by doing that with addition of the slight dietary modification, which should be low to moderate fat, moderate carbohydrate, and ketogenic diet can also help. High protein Mediterranean diet is very much useful for that. But if the people cannot do the diet management, people, those who are having some limitations even for the lifestyle modification, they can't do the exercise, they don't have enough time to do the exercise, they can't lose their weight for one reason or another reason, bariatric surgery is an answer for them. So what happens when we really do the lifestyle modification? उसका भी कोई पैरामीटर है क्या? लाइफस्टाइल मॉडिफिकेशन किया, वेट लॉस किया, तो उससे हमें कितना फायदा होने वाला है? Here you can see that the advantage is not small. It is a very significant and gross advantage. People, those who can lose their 10% and more than 10% weight, they simply get 45% of the patients get the fibrosis reduction. And if they really continue, sustain this for 1 year, this weight loss, this helps a lot in that. If the people are having 7%, अगर 10% वेट लॉस नहीं कर पा रहे, आपने 7% वेट लॉस भी किया, तो शायद फाइब्रोसिस रिग्रेशन नहीं होगा, लेकिन नैश रिजोल्यूशन हो जाएगा. आपका नॉन एल्कोहलिक स्टेटोटिक हेपेटाइटिस विल बी रिग्रेस्ड एंड विल बी कवर्ड अप इन 64 to 90% पेशेंट में ये रिस्पॉन्ड कर जाता है. एंड 18% लोगों में ये 1 साल तक कंटिन्यू कर जाते हैं चेंजेस. 5% लोग, अगर आपने वेट लॉस भी किया, then you can stop the ballooning and inflammation process, and in 41 to 100% of the patient, and 30% patient can easily maintain it for the year. 3% वेट लॉस भी कामयाब रहता है. 3% भी आपने अगर वजन कम कर लिया, तो आपका फैटी डिपोजिशन will go off in 35% to 100% of the patient, although we don't have the data for the 1 year sustainability. So once we talk about the NAFLD, who would be ideal patient to start with the medication? अगर हमने इतना कुछ करके simply by lifestyle modification हमने ये सब कुछ achieve कर लिया, then who are those patients in which we need to give the pharmacotherapy, give the medication? Those who are in the early stages of the NAFLD at high risk for the disease progression, age is more than 50 years, having the obesity, type 2 diabetes, hypertriglyceridemia, and hypertension, having the active NASH with high necroinflammatory activity, and this NASH is in the progressive stage with bridging fibrosis and cirrhosis. They are the candidate for the pharmacotherapy. But unfortunately, lot of pharmacotherapy which is available, that is off-label pharmacotherapy. Very few of the medications are really which are approved by various organizations and drug controlling authorities across the world, including the US FDA. So if we talk about the metformin, we don't have much evidence, but people use it. Vitamin E is largely used for the correction of the NAFLD. 400 milligram twice a day, 800 milligram once a day is the dose for that. But majority of the organization did not find enough evidence even for that also. But this is having at least some of the evidences. The evidence which are maximum available, that is for the PPR gamma agonist. So we are having the two different medications of the PPR gamma agonist class. One is the pioglitazone, which is used for the treatment of the type 2 diabetes, and another one is the saroglitazone. Saroglitazar is again now started to be used for the treatment of the type 2 diabetes. Initially, it has been introduced in the market just strictly for the treatment of the hypertriglyceridemia. But this is the only medication which has been given the approval of the US FDA for the treatment of the NAFLD or NASLD. So this is the, even pioglitazone has also been approved by the Indian Society of the Gastroenterology to be used for the treatment of the NAFLD or NASH, even those who are non-diabetic. But you can understand those who are using in their day-to-day practice for the treatment of the type 2 diabetes, pioglitazone is having a lot of reservations and lot of concerns for the patient, those who are using. But saroglitazar is actually not having those concerns. एक दवा जो सबसे ज़्यादा यूज होती है फैटी लिवर डिजीज का नाम सुना और आपके फिजिशियन ने उसको लिख दिया, दैट इज उनका ऑर्थोडिऑक्सीफोलिक एसिड. Maximum prescribed medicine and least amount of the evidences are available. No evidence is available, none of the organization has approved it, neither UDCA nor obeticholic acid. So effectiveness of the PPR agonist saroglitazar in non-alcoholic steatohepatitis have been proven in biopsy-proven trials also. Primary endpoint where we could see that decrease in the NAFLD activity score was more than twice observed in 52.3% of the patients without worsening of the fibrosis after the 52 weeks of the treatment while using the saroglitazar. So efficacy and safety of the saroglitazar in real-world patients of the non-alcoholic fatty liver disease with or without diabetes, including compensated cirrhosis. At tertiary care center, what we could see after the 52 weeks in a tertiary care center in Eastern India, the results were the improvement in the transient elastography parameters according to the baseline fibrosis you can see, but it's impressive in all stages of the NAFLD you can see. In all stages of the NAFLD, saroglitazar has performed better and well. To comparison of the NAFLD pharmacotherapy, if we talk about the effect of the insulin sensitivity with the saroglitazar, it is there approved for the NAFLD treatment, it is approved by the US FDA, decrease in the NAFLD activity score, while the vitamin E, pioglitazone and UDCA, they all having their own reservations and concerns, what I have already told to you. So now summarizing the talk, MASLD or metabolic dysfunction induced steatotic liver disease, which is redefined from NAFLD. So this is a new nomenclature. Association of at least one cardiometabolic risk factor is very much important to label any patient as MASLD who is having a fatty deposition. Either he should have the obesity or type 2 diabetes or pre-diabetes, hypertension, hypertriglyceridemia, low HDL. इनमें से कोई भी एक चीज है that you can label the patient as MASLD. Screening is recommended by the ultrasonography, FIB4 index, and finally with the Fibroscan, what I have already discussed in my presentation. Lifestyle modification is the most important treatment. Weight loss is the key for the reduction in the disease, and it can really be the sustained for a longer time for avoiding the untoward outcome. Drug like saroglitazar is the only approved medication to treat NAFLD with metabolic disorders in India, which can reduce liver enzyme, liver fat and fibrosis score as well. Now it has also been recommended by the Indian authorities and Indian organizations like RSSDI, like Lipid Association of India, like CSI, and of course the Indian Society of Gastroenterology. Thank you very much for your time.